corner of your screen if somebody can just type that they've got sound. Yes, that's good. Thank you, Emma. Okay. So I'm just going to say a couple of words, and then I'm going to toss it over to Dr. Kathy Rush, who's our presenter today. Just a couple quick words about the foundation. So the mission of the RTOERO Foundation is to foster respect, self-determination, better healthcare, and social connection for older adults in Canada. The foundation, we are actually one of a very small number of foundations who invests exclusively in initiatives related to healthy and active aging. So in terms of the webinars, this is now our third year of planning and hosting webinars. We're happy to continue bringing interesting and relevant topics and presenters to you through this webinar format. There will be many more webinars this year, and you will probably receive email invitations to register for those in the coming months. So look out for those. Again, thank you everyone who's joining today as a participant. We of course want to say that we hope everyone is staying safe and healthy in the midst of this global COVID-19 pandemic. These are very challenging times, to say the least. And as all of us undoubtedly know or are feeling, with so many of our regular activities now unavailable, it's very important to stay connected in ways that are safe, of course, and to use the tools that we have available to us to keep ourselves mentally and socially active. If there's a silver lining in all of this, it's that the pandemic, or one of the silver linings at least, seems that the pandemic has forced many of us to learn how to use and get comfortable with digital technology. Digital communication tools, they're challenging for many of us, but they have become an even more important element in keeping us informed, engaged, and connected to others. So, which actually ties in with some of what will be discussed in today's webinar. So let me do some very quick housekeeping, and then we'll get started. For everyone who's logged in, you should see the opening slide of the presentation on your screen, addressing rural inequities in healthcare. We'll begin the presentation momentarily. If you're having trouble hearing, please remember to just turn up your speakers, maybe if you have a volume on the speakers and or your headphones. If you look at the bottom right corner of your screen, you'll see a chat box area. This is where you can submit questions. You can submit them at any time during the presentation, but we're going to hold the Q&A till the end. And we'll do our best to answer as many as we can during the Q&A section at the end of the presentation. And if you're having any issues with the webinar, you can use that chat box as well to let us know. We'll do our best to solve issues as we go, keeping in mind we're not a tech team, but we'll do our best if anyone's having issues. The presentation will take 30 to 40 minutes probably, and then we should have 10 or 15 minutes for a Q&A at the end. One last thing, at the end of the Q&A, at the very end of the webinar, and this is very important, a short survey, a very short survey will pop up on your screen. We'd like to ask everyone to please just take 2 minutes to complete the survey. It's really easy because your feedback will really help us improve our webinars in the future. So thank you. Let me introduce our presenter and let's get started. I'm very pleased to have with us today Dr. Kathy Rush. Dr. Rush has taught at universities in Canada and in the US. As she is presently a professor at the School of Nursing at the University of UBC, Okanagan. Dr. Rush is actually a former RTOERO Foundation grantee. Her 2017, I think, project around urinary incontinence aimed to increase awareness around incontinence in older adults and promote timely treatment. And she was able to complete that project in part through the financial contribution of the foundation, but also through data that she collected through participation from RTOERO members. So there was a great synergy and connect between RTO and the foundation and Dr. Rush's work. That was a few years back, so fast forwarding to the present, Dr. Rush's newest research program seeks to support older adults with cardiovascular conditions who are living in rural communities. Her ongoing research project, and she'll speak to this today, is exploring the use of technological solutions to address rural inequities in health and healthcare. She also wants to mention that she's an avid runner and says she's found it very challenging navigating running spaces with others during these COVID-19 times, which sounds about right. So Dr. Rush, thank you so much for joining us today, and I'm going to turn the presentation over to you.
Great. Thank you, Mike. I am delighted to be able to be part of your kickoff webinar for 2020, and I hope that you can hear me. I've been having a few little buzzing sounds. They seem to have disappeared at the moment, so hopefully they will not interfere with the presentation. But I am very happy to be able to share with you some of the research that I have been doing in terms of addressing rural inequities in healthcare. And would like to just acknowledge some of my team members. We have a fairly large team that includes some UBC researchers, some patient partners. We have a tech vendor who is a physician who actually is basically designed the particular personal health record that we're using in our work. And we also have representation on our team from the ministry with the Chief Medical Information Officer who is leading the Provincial Digital Health Initiative as well. So we have a very great team to be working with, and I'm delighted to be able to share a little bit of the work that we've been doing, and it is just a small piece of what we have been doing. So I'd like to really start off with really what is the problem that really drives this research? And really, it's about some of the inequities and the disparities in health and healthcare experienced by rural communities. And you'll see on this slide just some of those disparities. So compared to urban populations, rural populations are aging more quickly. We just have proportionately more older people in rural communities than in urban communities. Rural populations also have a higher prevalence of chronic diseases that might be associated with the fact that they have older populations as well. But in addition to just a greater prevalence of chronic diseases, they have more multiple chronic diseases. So people with 2 and 3 chronic diseases and even more. More often, rural populations have poor mental health, unhealthy behaviors, and obesity, and have lower life expectancy and higher mortality that is potentially avoidable. So you can see from this slide that where people live matters. And I'd like to just share a little bit about the geography of the region in which we are doing our research. It's the British Columbia's Interior Health Region. And you will see on the map that it is a very geographically dispersed area covering almost 215,000 square kilometers across really low density rural areas. And if you take a look at this map, there are various colors. It's largely gray, but there is lots of spotting with yellow and light orange colors. The gray really represents no population density at all, whereas the yellow represents low density areas. And then as we move up to scale, you can see oranges and reds that really show high population density. And those are more the urban based areas. And so you can see just from this map alone that we do have a very low density rural landscape that we are working in. Also in rural communities, we know that there are primary care provider shortages. This is not unlike the urban centers, but the challenge with rural communities is that oftentimes primary care providers go to an area for maybe 1 to 2 years and then they leave. And so there's this constant revolving door of primary care providers in rural communities. Also, there's some evidence to show some mismatch between access to primary care providers and demand, particularly in areas where there are older populations, where there's even greater need. And primary care providers tend to have large, complex caseloads, probably because they do have older caseloads with more comorbidities. As well, in rural communities, as you might well expect, they have a decreased access to services, specialty services like psychiatric services, cardiac services. And this is not true of every rural community, but in general, they have certainly decreased access compared to their rural counterparts. And of course, that necessitates travel to those services. And with that, associated costs and safety. Certainly, there are large distances that they must travel to get to those services, but they are also traveling across really rugged terrain, mountainous areas that are very treacherous, certainly in winter months, and can pose risks to their safety. And there's just the inconvenience. A lot of older adults perhaps cannot drive, and they have to find somebody to to drive them to an urban center for services. Not only does it matter where people live, but it also matters what people do. And so people best manage their chronic diseases when they are actively involved and participate in their care. And in turn, that active patient participation improves several things. So certainly it improves disease control. So for example, diabetics have better or more stable blood glucose levels. It improves really healthy behaviors, whether that's healthy food choices, whether that is more physical activity. It also enhances treatment adherence. Oftentimes medications and patients who are much more actively participating in their care, they tend to be more vigilant in terms of taking the right medications at the right time, and so on. It improves quality of life. Greater active participation, and likely because it also improves all these other things. And it also enhances communication with health professionals. So there are lots of benefits really to active patient participation in their care. And so to address some of the rural inequities in care that I mentioned in the previous slides, and to optimize chronic disease management through patient participation, we are trying to leverage technology in the form of personal health records. And some of you, perhaps many of you, have had experience with personal health records or know of someone who has had a personal health record. But a personal health record is an electronic tool for patients to access, to manage, and share their health information in a private, secure, and confidential environment. This is a rather busy diagram in front of you, but you can see in the middle the patient owning their personal health record. And you can see arrows sort of going out to and from the personal health record. If you look at the left, you can see that patients can actually be collecting information with things that they wear, wearable devices like watches, or mobile devices on which they have apps. And that information that they're collecting could easily be uploaded to a personal health record. And then you'll see on the right that there are health providers, for example, and you know all of your health providers have electronic health records. They have been around for some time, and in some cases, the personal health record, the patient's personal health record, can be integrated with the electronic health record. Sometimes they're just standalone. Personal health records can be just standalone, but sometimes they are integrated with an electronic health record of a healthcare provider, and that's what we call a tethered personal health record. And I just wanted to present some types of data that can be stored on a personal health record, and this is by no means exhaustive, but you can see, for example, allergies or family history details. I mentioned home monitoring, so blood pressure measurements or other things certainly can be included on a personal health record, as well as a list of major diseases, medication lists. So there are a variety of things that can be included on a personal health record. Personal health records have been shown to decrease emergency room visits and hospitalizations for patients with chronic diseases, as well as to increase patient satisfaction and disease control. So diabetics, for example, who may have better glucose control, patients with hypertension who have more stable blood pressures. But despite these benefits of personal health records, the uptake has been slow. One of the factors, and it is only just one factor that has been thought to explain some of this poor uptake, has been the fact that we haven't really talked to the people who use them. And so we haven't tended to learn from patients and or providers about what their views are on personal health records. So that's been largely missing from the research literature. And most of what has been done with patients separately from providers. So there's been no comparison of the views of patients or providers. You will see that on the left, there have been the limited work that has been done does show that providers tend to report benefits with personal health records, but that they also tend to emphasize the downside of the records by, considering that there may be threats to their practices, to workload, to their flow, patients and privacy is a concern. They also have tended to be pessimistic about patients' motivation and their ability to maintain an electronic personal health record. And they also have expressed doubt that patients can provide accurate information. There hasn't been much evidence in terms of patients and their perspectives. And the one study that I report here really was of patients who had actually used a personal health record for a few weeks. And patients did report that it increased motivation, that it enhanced their partnerships with their physicians and improved communication, and it gave them easier access to information. And there was only really one study that we found that really compared patients' and providers' views of personal health record, but it was an urban-based study and not conducted in a rural context. So for that reason, and for all the reasons that I've really outlined to date, the purpose really then of our study, and this is just phase one of a two-phase study, is to really understand rural patients' and providers' perspectives of personal health records before their implementation within primary care networks in one rural region of British Columbia's interior health. And primary care networks, I think, probably would be familiar to many, to some or all of you. They're just really teams of primary care providers who really together are really caring and serving a particular patient population, and they can connect patients to services in the community and elsewhere, so that patients are really getting comprehensive care through these networks. I wanted to just mention that we were also interested, and I wanted to I guess I should go back here to this slide, but I mentioned that this is phase one of a two-phase study. And in the second phase of the study, which is underway, we have implemented a collaborative personal health record to understand patients as partners in a rural primary healthcare context. And so I use that term collaborative because I wanted to just identify that a collaborative health record is really one that is more connected to a primary care provider, and it has the following features. So it has secure texting, secure emailing, it has appointment scheduling, so you'll see a calendar there to schedule appointments, video conferencing, and it has a whole library of tools to measure patient-reported outcomes, such as depression or anxiety or other types of measures, health-related measures. So we used a qualitative study, which is really just about talking to our users, to patients and to providers. And we invited all providers from the primary care network clinics in which we are doing the study. And we also invited patients from a patient advisory committee in the region to participate in the study. So just to give you, and we conducted separate focus groups. So we held patient focus groups separately from primary care provider focus groups, and we asked patients. We asked our groups a variety of questions. We wanted to know about their understanding of personal health records, what they valued in a personal health record, what features they thought were important in a record, and also their perceptions of the benefits of patients generating data for a personal health record. And then we analyzed all of these focus groups to come up with some themes that I will be talking about. I did want to mention that we also did not define what a personal health record was for our participants before we had them talk about them. So you'll see here that we ended up with a patient sample of just 9. We would have liked to have had more, but we did have 9. And you'll see that with an average age of about 60, primarily female, with quite well educated with college and some college. They reported always or regularly using technology, so they were certainly exposed to technology, and they lived really a relatively short distance from the clinic, about 6 kilometers. And I didn't include it here, but in terms of their health status, we did have them report on their health status, their physical and mental health status, and there were varying levels, really, from very good to fair. So it wasn't just, it was a group that actually had a range of health needs. And then you'll see that we had a much larger provider group. There were 17 providers, mostly female, with primarily general practitioners, but we did have representation from medical office assistants, nurse practitioners, and registered nurses. So again, that idea of a primary care network. And they tended to be pretty high-level technology users with advanced to average, and then just a couple who indicated that they were basic users. And most of them had been in practice for approximately 10 years plus. So just to report then some of the main themes that we found. So patients and providers shared similar but subtle differences in their views and understandings of personal health records. And you might expect that. Certainly their views were based on different contexts, kind of the professional context of the providers, more personal context of the patients, and they had had different exposures and experiences with personal health record features. So as you would expect, the primary care providers, because they had electronic health records, had worked with electronic health records, had had much more exposure to many of the features that are similar to some of those that are on a personal health record. Patients tended not to have as much familiarity or exposure, and most of them had experience with using a patient portal where they would be able to access their lab work findings. There were two main things that represented patients' and providers' views of personal health records that I'll elaborate on here, but they both certainly supported the need for a personal health record to be patient-oriented. But they did have different orientations in terms of their perspectives. And they also both supported the value of flexible and fluid communication and information sharing, but they also both saw the need for some communication boundaries. So the patient-oriented focus was important to both groups, and they really viewed it in four main ways. As by providing a comprehensive health illness story, by giving patients agency and control, by empowering patients, and by housing patient-generated data or information. So that's data or information that is generated by the patient, not by the provider. And additionally, providers also highlighted some concerns about patients using personal health records that I also will talk about. So in terms of providing a comprehensive health illness story, providers certainly saw the personal health record as connecting to multiple providers to keep information up to date. And they talked about being able to access consult reports through a personal health record rather than having to wait to receive a consult in another way. Patients also certainly saw the value of this comprehensive health illness story, that it included their total health, and it included all the pieces related to their health, because as one patient participant said, if there's missing pieces, then it can all fall apart. So it needs to be comprehensive. Providers and patients also saw that a comprehensive health illness story that was housed in a personal health record also could address gaps in care. And providers in particular saw that this was important for patients who were quite transient, who moved around a lot, whether that was from province to province or from town, city to city within a province. And they also saw it as very valuable for people using the ED for the first time. This would be particularly for people visiting in a rural community who would be unfamiliar to providers. And so they saw the value of having information to catch them up on that person's history. Patients saw a comprehensive health illness story as invaluable in averting the need to repeat information. And there were some patients patient participants who talked just about having to, especially those who had had histories of abuse or trauma, as having to go back into the story and repeat information that often could trigger setbacks for them and not allow them to progress in their management of their chronic disease. Providers and patients both saw that a personal health record would provide greater accuracy, frequency, and currency of patient-reported data. And certainly patients oftentimes will be keeping records of perhaps daily blood pressure. And so that type of information could be added to a personal health record and then be available to providers, for example. That kind of frequency would not probably be this. That kind of frequency would really be helpful in looking at patterns and trends over time. And also, patients could also keep a record more current, so that if, for example, they were starting on a new herbal medication, that might be information that would be important to include in a personal health record. And it simply might not be information that comes up during a patient visit, but comes up for the patient after the fact, after they've left. And so that kind of information could be added to a personal health record. So it was interesting that patients did raise the possibility that fear or stigma in some instances could contribute to inaccuracy or incomplete reporting by patients. But it was interesting that a retired physician who was involved in the patient group said, I think the patient, even with filtering, is far more accurate than what's reflected in the record. And there certainly is some evidence showing some discrepancies between patient histories and physician notes. So perhaps that retired physician had some insider knowledge about that. But despite the fact that they thought that there was greater accuracy, frequency, and currency of patient-reported information, they did have different orientations to that patient-reported information. And so providers, although they endorsed health-related data like sleep data, they overall prioritized illness data. And so these are just some examples of the types of data that physicians talked about that they thought would be very valuable to be included in a personal health record. So symptoms, glucometer readings, insulin dosing, medication compliance, those type of things. In contrast, patients were much more health oriented. And so they talked about being able to include food logs or exercise records, those types of things. And you'll see that this particular patient participant also contrasted a provider-patient perspective. I think the information that I keep is more around a health promotion, wellness perspective, whereas if I compared that to what's in the health record currently, it would all be around sickness and illness. It was important in terms of having a patient-oriented personal health record that it give patients control, and both providers and patients did support the importance of patients having control through a personal health record. You'll notice that patients were unanimous that they should control or own their personal health record data, and they talked a lot about being the gatekeepers and the owners, particularly in terms of access to their records, determining what information is shared and with whom it should be shared, and also allowing them to make changes, such as correcting incorrect entries. So if someone else was adding to the personal health record, they could correct it or make changes to reflect their values. You'll see that providers were not unanimous, right, in patients having control, but they felt that there were varying levels of patient control. Some felt that patients should only have read-only access, so they could, similar to a portal where they could go in and read a report. Others thought that it should be a shared endeavor, that both groups had important contributions, or there was important information that both had to share, and it should be it should reflect that. And then others thought that the patient should have ownership and control of their personal health record. And one nurse practitioner said, "That's my nirvana dream." Although they did have varying levels of perceptions of patient control with respect to a personal health record, the providers acknowledged that patients do have the right to access their health record information, but they really conceded that they were really currently the gatekeepers of the record. And that's a lot that does have a lot to do with infrastructures that are in place as well. Unique to the providers, and this is not something that came from the patients, but was the fact that a personal health record could empower patients. And so providers really viewed access to information as quite valuable. They thought it would be valuable in motivating patients to carry out action plans and staying accountable for various aspects of the care plan. They also thought that certainly having information prior to a visit, for example, being able to access information prior to a visit, which currently some patients do have, is useful in allowing appointments then to be more patient-oriented, and being able to address patients' concerns and questions. And they just thought it was useful in allowing for shared planning to help patients with their own self-management. But providers did have concerns about the impact of personal health records on patients, and they talked about patient literacy. They were concerned about the ability of some patients to understand information because some of it can be quite technical, which then creates some frustration for patients. Or they were concerned about patients misinterpreting information. And so they talked about, for example, a patient looking at or seeing a lab report and seeing a value that was maybe just outside the normal range, and how that could create undue anxiety for a patient when in fact it just being outside might be something that was quite benign for a patient. So they had concerns around just that those literacy aspects. They also were concerned that with having sort of a comprehensive personal health record, that it might negatively impact the patient's care, particularly if patients had had some negative relationships with past providers. They were concerned about what kind of light that might cast on a patient, and it might be quite negative versus, as one provider said, having a fresh perspective of the patient. They also mentioned concerns about how patients with impaired mental capacities could use a personal health record, and that might be that would certainly be a legitimate concern, and it may not be appropriate for use by some groups. They were also concerned about patients without access to the computer, but many personal health records are accessible by phone, and many people do have a phone. The second big theme that emerged also was the value of flexible and fluid communication and information sharing, and both providers and patients liked that aspect of a personal health record. Providers particularly liked the flexibility in terms of being able to maybe use other modalities besides an in-person visit, like using secure texting or videoing to maybe talk to a patient who had missed an appointment, or to maybe follow up with a patient who had had an unstable condition that they saw in the ED, because many rural physicians also work in the ED, and they were maybe just a little concerned about what had happened, and so they could follow up in with those short texts or a brief video. Some providers also thought it would be very beneficial for providers who worked part-time, and there were some groups who did. They also thought that that flexible, fluid communication would promote greater efficiencies by really using those brief interactions with some patients to reserve office visits for those who needed to be seen. And patients also were supportive of this very flexible, fluid communication. They didn't talk to it as much as providers did, but they certainly had benefited from emails back and forth with providers, and thought that was certainly essential. But patients really focused on the transfer of information from one provider to the other. They felt certainly that having a personal health record would allow that seamless communication and information sharing between providers. But at the same time as they valued this flexible and fluid communication, they also felt that there needed to be some boundaries set on it. And so providers were really concerned about workflow interruptions, how it would disrupt what they were currently practicing, and the extra time that might be required to communicate with patients, especially through texting. So if they texted and a patient texted, and how much of that might go on. And that really largely reflected their unknowns about the extent. They did, of course, because this was pre-implementation of a personal health record, they didn't really know what they could expect in that regard. It was interesting, though, that an NP practice had already started using some of these other modalities of communication, and they had that same worry, but they said, we were quite worried about that. What they would be messaging back, what patients would be messaging back. We thought we would be hit out there, but they're not abusive. And so patients, they were kind of reassuring that really patients were really using it for its intended purpose and not overusing it or abusing it. Patients didn't have the same concerns as providers. Their concern was more related to the nature of the information that was shared. And while patients did desire to have their data shared, they wanted to set limits on it as well. As one participant indicated, to wall off areas, if you will, that we just share with our mental health provider, or areas that we want to make open to others. But it should be under the patient's control as to who gets what. So basically that sort of is all of the themes, and I just sort of wanted to conclude this presentation. So overall, patient and provider views were positive and they harmonized. So there was a great deal of agreement between patients and providers with respect to personal health records, even though they hadn't really used them per se. But there was some divergence, as I've already alluded to. And so there were these differing orientations to the patient-reported data. So patients having this more health focus versus the illness focus of the providers. So I just sort of speculate patients' interest in using the personal health record as a tool for health promotion may facilitate a shift away from maybe an illness focus to more of health behaviors and illness prevention. And then, of course, we saw that there were differences in the extent of control of the personal health record and who's the gatekeeper. And our use of a collaborative health record, we think, may reconcile these differences where there actually is integration of a patient's personal health record with a provider's electronic health record. And of course, both patients and providers did cite advantages to having the personal health record profile that whole illness story over time by giving continuity from provider to provider in terms of their history and over time, giving context, completeness, and particularly avoiding the repetition of information. But we saw that it might have some detrimental impacts if there were some negative things housed within the personal health record. Providers viewed the personal health record as an opportunity to motivate and empower patients. Even though patients really didn't raise this so much, other research has supported that patients do feel empowered with the use of a personal health record because they know more, because they're seeing more. They see what providers see. So they have more access to that information and are more informed. And then, of course, we saw that there was some flexible, they both valued flexible communication, but they valued but they raised issues about boundaries, and that may certainly need to be negotiated between providers and patients in the adoption of personal health records. And those are just, I did want to just provide another couple. I wanted to acknowledge the funding provided by the BC Support Unit for this project, and also to my research coordinator and assistants who have contributed to the project, and for the invaluable participation of our clinicians and patient participants who really made this study possible and are continuing to make phase 2 of this study possible. And then, of course, we had additional support for this project from our technical vendor, Input Health. And contact for any future research studies. If you are interested in or would like to receive information about any future studies regarding technology use with older adults with chronic conditions, please feel free to contact me. We would love to be able to put you on our mailing list. Mike, I think that that's it for me for the presentation component of this.
That's excellent, Kathy. If you could just leave it on that slide if anyone's jotting down your email address there. Would be great. So thank you, Dr. Rush. That was great. The work you're doing is always so interesting, and of course, very, very important. We're now going to open up the Q&A and spend some time answering questions as they come in from attendees. So remember, everyone who's on the line, please use the chat box. It's at the bottom right of your screen, and you can just submit your questions that way, and we'll take them as they come. We may not have time to address all of them, but we'll do our best. So maybe just to get things started, if you don't mind, Dr. Rush, I could just throw a question out there. Could you clarify a little bit for us the difference between a personal health record and a patient portal?
Sure. I did mention both of those in my presentation, and there are some overlaps with them, but by and large, it really is about who owns them. And generally, a personal health record is really owned by the patient, and the patient can manipulate it, they can add to it, they can change, make modifications to the information. Whereas a patient portal is generally owned by a provider, and the provider gives patients access to that portal. And so many people would have experience with having used patient portals with respect to picking up their lab values. But again, that is not something that a patient would be able to change or manipulate, but they would be given access to it. So it's largely that ownership piece and the kind of the level of activity that can occur. So patients being able to really manipulate and do with the personal health record what they would like with it, whereas a patient portal is not under their control, and therefore they can really largely just read it and access it, but not really manipulate the information.
Okay, that's helpful. Thank you. Okay, we do have a number of questions coming in, so we'll take these again as they come. We're going to try to use a function here where the question will actually pop up on the screen for everybody to see. So we'll see if we can do that. There's a question. The first one here, I'll read it out to you. Actually, there's a question here that says, "Do you know if there are any similar studies in other provinces?"
I know that there have been some studies in other provinces. I don't know that there have been pre-implementation studies like we have just kind of completed that phase 1, but there certainly are some things going on in British Columbia. I think in Ontario, I have come across some earlier work, perhaps in the early, like 2011, 2012, with primary care physicians having maybe used a personal health record or a portal of sorts. These particular studies are fairly limited, even though personal health records have been around for quite some time. I'm not aware of a whole lot of work going on in this area, because even in our travels looking for research related to this area, it was probably mostly from the States or other countries, and very limited in terms of a Canadian presence. But it is starting. I think it's certainly starting to escalate a little bit more, but I honestly can't give you any specific studies going on in other provinces. I'm sorry.
Okay. No, that's good. I think that does address it. There's another one here. Where is it? So this one's from Jeremy. It says, "Do you think that the resistance to personal health records is due to privacy issues?"
I think, Jeremy, that is probably another really big reason for the lack of uptake of personal health records. I do think that it may be a misunderstanding, though, in terms of people not perhaps understanding that generally these personal health records are vetted through privacy, and so generally those things that are those products that are on the market would tend to be required to conform to our privacy regulations. And but I do think that probably accounts for some of it. Is just the fact that people are really concerned about it getting into the wrong hands, and whose hands might it get into. I think that probably, if you have a standalone personal health record, I think that is sort of completely under the patient's control. But if your personal health record is attached to another electronic health record, a provider's health record, or some other connection, then there probably is a greater risk, or people concerned about a greater risk of privacy, even though generally those things are really looked after, and there should not be anything sort of happening outside of a proper professional context. And so it should only be accessible to those people who are caring for a patient, and not in the wrong hands, so to speak.
Okay. Here's another question. This comes from Melanie. Kathy, are you able to see these?
I can, yes.
Okay, perfect. So I'll just read it out. But has limited access to quality rural broadband technology access impacted the use of technologies in rural communities for PHRs?
Yes, I think that that's a good point, Melanie, because I do think that many rural communities do lack that rural bandwidth. And so it does make it very challenging. I know even when we were interviewing patients and providers in the rural communities that they spoke about that, and just some of even how video conferencing and those connections were oftentimes influenced, or texting, phone use, those were all affected depending on where people lived. And so I do think that you make a really good point that has been certainly a factor against use of them, or a factor influencing the ease of use of them. I know that in our province, that certainly there's been much more. The government has actually invested in trying to increase the broadband width to ensure that there aren't limitations in terms of our rural communities' access to technology and the use of technology for health applications and other applications as well.
Thanks, Kathy. I hope that answers the question, Melanie. Here's another one. This is a pretty broad question, I think, but Dr. Peter is asking, has anybody addressed the legal implications?
That's a great question. I would say that certainly in some of the literature that I've looked at, there has been concern, particularly among providers, around legal implications, and they do worry about how information that they document in a record might be used against them. And so even our rural physicians who did talk, and providers, it wasn't just physicians, but our providers who talked to us did talk about their concerns about the legalities, and how they might actually have to be careful about what they document just because of concerns around legalities. So I think you raise a really good point that has been raised by providers. I don't know that it actually has been legally I don't know, it has legal implications, I think, but I don't believe that those would, I would say that they've really been adequately addressed. Peter?
Okay, thanks, Kathy. I as we're talking about this and thinking, and you spoke a lot of what you mentioned today in the presentation was about from the patient perspective. It's just to throw a sort of a broad question though out there. It seems like the PHRs could be a lot of work for the patient. So, do you? I mean, I'm assuming you do, but you feel the benefits outweigh, the cost or the burden or the inconvenience to the patient. Is that a fair thing to say?
Yeah, I think that they do. I think providers raise the point about patient motivation and how motivated patients would be in terms of keeping these kinds of records. And I think that there is a continuum of patients interested in, some patients who are very vigilant in keeping records, and they would find personal health records very valuable, an electronic version of what they already do in some sense. And then there are others who really just want to go to the doctor to see what's wrong and not really to have much ownership of their health. And so I do think that we have sort of a continuum of people who would be, who are receptive to this kind of effort, because I think it does take work, but I do think that it actively involves the patient in their own care. And I think we saw several of the benefits. I did mention several of the benefits of being able to participate in your own care. And so I think the benefits, yes, I would say outweigh, but it might be a real change in behavior for many patients, because they might not be used to really keeping on top of their health, basically their daily health, in the way that a PHR might demand of them. But really, it's a patient, and so the patient has ownership of it. They can include in it what they want, and so it can be a little or it can be a lot. And so I guess like I said, there's a continuum of users and user interest and receptivity to this kind of thing. But I do think that the benefits outweigh the burden, Mike. Yeah,
that sounds right. Here's a question from Mike Highland. who says he lives, in an urban setting in the winter, but he's at the cottage in the summer,
Mhm.
and he's clearly seeing the value of a PHR for himself. But he's wondering if there's a particular form of health record or a format or something that he would suggest to his provider. Does
Hmm.
that make sense?
Yeah, yeah, it does. Yeah, and it does depend, Mike, whether whether you're interested in having a personal health record that you would just have. It would be a standalone, or if it would be something that you would like to be able to be connected to your provider's electronic health record. I mean, there are different versions of a personal health record, and like I said, we're using one that is more of a collaborative record. Um, but I think that I would just maybe mention to your urban provider that you might be interested in a health record, and see what they say, because it may be that they might be interested in being able to um, uh, they might be interested in a more collaborative version where you could actually be connected to theirs, or they might want to suggest one in particular that they have found perhaps with patients that they work with. So I guess I would really talk to your urban provider, because I'm not sure about some of the vendors that you might have in the area that you live, that might be worth considering. So I think it partly depends on how you would like to use it, how your provider would might consider you using it, and how maybe together you might be able to come up with some kind of a plan for how a personal health record would really be helpful to you living at a distance from your urban center in the winter.
That's
Yeah,
great. Thanks.
yeah,
Thanks, Kathy.
yeah.
Okay, well, it's a couple minutes to 3 o'clock. We're nearing the end of the webinar. For everyone who's on the line, please don't leave us yet. We just need 2 more minutes of your time. Thank you to everyone who joined. If you could, you should see a survey that's come up on your screen now. It's just a couple of quick questions. If you could all just take 2 minutes to complete the survey, we'd be very appreciative. As mentioned, this is feedback. It's important to us to work to constantly bring you high quality webinar program throughout the year. So thank you. I want to give a big thank you to Dr. Kathy Rush for being with us today. Thank you. Thank you, Dr. Rush, and sharing her
Thanks.
expertise and an update on her research.
Great. It was my pleasure.
So in closing, I guess, just as everyone's just completing that survey, please also consider visiting the RTOERO Foundation. Visit us online, learn more about our work, and consider becoming a supporter so we can continue to fund important research and share knowledge and raise awareness on issues that are affecting older adults. So everyone, again, please stay safe and healthy. And again, thank you for joining us today. And if you could just take a minute to complete that survey, and then we're done for the day. Thank you again, Dr. Rush. We very much appreciate it.
Thanks so much. Have a great day, y'all.
Thank you.